one of the shining lights of that hospital. There was an article written in the Journal of the AMA in 1928, no, I'm not that old, 1928, by a family physician that said that the secret to caring for the patient is caring for the patient. And he is the epitome of that. He has done lots of things in leadership at Piedmont Mountainside Hospital. He is a listener. He listens to his patients. He talks to his patients. He takes all the time in the world. We were just discussing, reminiscing about some of our time together down in Jasper before I retired from Piedmont Healthcare. But he has not only taken leadership roles at that hospital and within Piedmont Healthcare, but and he has been running the hospice program, palliative care program at Piedmont Mountainside Hospital. One of our sessions last spring, we felt was really inadequate in discussing palliative care and hospice. So I asked him to come and talk to you of his philosophy, which is a very refreshing philosophy about end-of-life care, palliative care, and hospice, and that's what he's going to do this afternoon.
Well, I first visited Fannin County in 1972. One of my classmates was Keith Jones, who grew up here, and we came home with Keith one weekend, met Grover and met his mama, and I couldn't believe what it looked like in 72. When I got to Jasper in 82, it looked a lot different, and now, gee, you can't even tell. So that was great. Also, my residency was in Columbus, Georgia, and Jack Roof was one of the residents that was about 5 years ahead of me. But as we were looking through medical records and things like that, you kept seeing Jack Roof's name in Columbus. So I feel connected to this part of the country. I tell people if they went to sleep here and woke up on Sand Mountain, they couldn't tell the difference. They really wouldn't be. So I'm gonna talk about a few things, and I'm pretty opinionated, and only when I'm asked to talk do I really promulgate my opinions, and I'll try to make a difference between opinion and fact, and let you know. This is Truman. This is my 4th generation of Labrador Retrievers, and Truman's birthday is today. He's 8 years old, so I brought Truman with me. He's an emotional support. He is my emotional support animal. So, I didn't know what you wanted, so I just thought I would do my end-of-life discussion. And similar to the way I talk to patients and families sometimes, how are you going to die? How do you think? 50% of us are going to die because of heart attack, stroke, or aneurysm. Okay, and hopefully it's age 92 instead of age 72, but that's still what it's going to be. 25% of us are going to die because of cancer. What's the number one cancer that kills men and women? Lung cancer. Lung cancer is associated with smoking. 85% of lung cancer patients are smokers. 15% have a clear secondhand exposure or industrial exposure. So, what's the number 2 cancer that kills men and women? Colon cancer. That's why you get your colon cancer screening. That's why you want your colon cancer screening, because it's the number 3 thing that's going to kill you. And then for women, breast cancer, cervical cancer. And one thing about cervical cancer is interesting. An HPV vaccine is going to eliminate cervical cancer in our lifetime if we let it. Cervical cancer patients who die are like 48 years old. Cervical cancer is related to the total number of different sexual partners a woman has in her lifetime. And cervical cancer patients will be young, and they'll die at age 48 and 50. It's horrible. It's awful. Local invasion and metastasis. And then, see, what's next? Automobile accidents. Still up in the top 5. If you die in a car wreck, it's going to be due to speed, seatbelts, or alcohol. And what's next? Emphysema from smoking. Smoking's on the list 3 times. And then complications of diabetes. Diabetes is still the number 1 cause of renal dialysis in the United States and the number 1 cause of blindness. And then Alzheimer's. So if you want to die of old age, you got to skate through that maze of the other things. But when you get then to the end of life, where do we die? Half of us die in the hospital, hooked to a lot of different things. And there's a lot of, there's an interesting thing I'm going to bring to you too. So half of us are going to die in the hospital. Only half of us are going to die peacefully at home, like Melanie in Gone with the Wind telling Scarlett, I know you've always loved him, take care of my husband. But it used to be that the end of life was a time, and the time around death was a time for meditation, for being together with the family, for meditation on your life, and there were even books published that purported to try to help you at this time, spiritual meditation and guidance and stuff like that. But most of the time we die behind closed doors, hooked with tubes in every orifice that's available. So if you'll just go to the internet and Google 3 words, doctors die differently, it'll give you about 3 pages of references, and you can go look at it. Doctors die differently. Doctors die differently. So, doctors die differently. Physicians often do not request complicated treatment and life-sustaining therapies. We can assume that it's due to their knowledge of just how violent and futile those efforts typically are. Also, doctors and lawyers. Lawyers, only 30% of doctors die in hospitals instead of 50%. About 40% of lawyers die in hospitals. The 60% die at home. 70% of doctors die at home. Doctors and lawyers have the resources to enable them to die at home. Suggests the financial concerns and lack of caregiver availability may be barriers to dying at home for people who are less informed. So, CPR. How successful is CPR in the hospital? How successful is it on TV? On TV, CPR is successful 75% of the time, with 67% of patients ultimately being discharged from the hospital on TV. In real life, a study that was done in Japan, 95,000 cases of CPR. 8% of patients who received CPR survived for more than 1 month. So CPR was invented in the 60s for sudden, unexpected heart death. And it sustains blood flow while you can get somebody with a sudden, unexpected heart attack. But we do CPR for lung cancer patients. Gee, what in the world is up with that? You got a lung cancer patient, or any patient in the ICU, over 80 years old, and they're hooked up to a couple things. And the family is looking at the doctor saying, isn't there anything more that you can do? Wait a minute. Yeah, there's always something more that you can do, but should you? And so that's why I bring up doctors die differently, and why I would recommend that you start thinking about medical things as a transactional analysis. So every procedure and every medicine that you take has a cost, not in dollars, but a cost and a benefit. So the cost, what's the cost of a gallbladder operation? Well, it hurts. and you have pain afterward. You have to do surgery, and you have risk of surgery. So that's a cost. Well, what's the benefit? Once that gallstone is gone and the gallbladder infection and inflammation is cleared, you can eat without nausea and pain. So the benefit is way above the cost, right? All right, so take everything, the cost of a shot of penicillin back in the old days. We don't do that anymore. But the cost of a medicine, risk of side effect, benefit of curing an infection. What's the cost of a congestive heart failure medicine? Side effects, okay, make you feel funny, make you feel bad, but less shortness of breath. But look at the closer the cost gets to the benefit. What's the cost of chemotherapy? The benefit of curing cancer. Chemotherapy has never cured a solid tumor. It gives you time. And I say that as a rule. There's always going to be an exception to the rule. But in general, it just gives you time. So how much time and how much discomfort and nausea and hair loss. So the costs rise, the benefit and the cost get closer together. And then at our age, I'm 72 this month, at our age, we should really be thinking about the cost versus the benefit. What if the cost exceeds the benefit in our own estimation? And you get to choose, you get to decide. It's your decision about the benefit. But if the cost exceeds the benefit, then maybe you should just say no. I'm not. My wife came in and she said the vascular surgeon was going to do a vein procedure. And I said, really? To what purpose? And she said, well, my legs have been achy and I've got these veins and I went to see him and he said those were the ones that needed to be blocked off. And I said, really? Did he tell you what the adverse effects were going to be from that procedure? No, they didn't really talk about that. Maybe you ought to call the PA and ask her, what are my legs going to be like after these veins are blocked off? So she said, well, they just said those were the ones that needed to be done. You need to think. I'm not telling you what to do, but you really need to be informed. We're not informed consumers of medical care. We need to be informed consumers of medical care. So it's a transactional analysis is what I encourage you to be thinking about all medical procedures. So survival in cancer, it goes like an ellipse, right? It starts and then the graph goes down, right? But like an ellipse, there's a long little tail where there's 2% survival for 15 years. But then 50% of people die within 6 months for this particular cancer, and then another 75% die within 2 years. And then there's that little, you want that, everybody thinks they're going to get the tail. Everybody thinks they're going to get that 15-year, 20-year tail. And somebody's going to get that tail. It's probably not going to be you. So we have to be a little bit more realistic about that. We have to be more accurate. Doctors have to be more accurate in their prognosis and their, rather than speaking kind of nebulous term. Oh, the 5-year survival rate, or this chemotherapy extends survival by 60%. Okay, well, let me think. Instead of 3 months, I get 5 months. Yeah, that's 60%. Yeah. So really and truly, you want details. You want information. You want details. You want something you can work with. And when you decide that the cost of something does not warrant, that the benefits are not enough for the cost, you can say no, and you can choose not to do things, not to be that patient in the ICU who is saying, can't you do anything more? you can change your focus to, let me have a good day today. If my days are good, then they don't have to. Then I don't have to have a bunch of miserable days if I can have fewer good days. And that's a personal decision. That's really, really up to you. You want to think about things like, what is it that you don't want to give up? And one neurosurgeon told his daughter, as long as I can eat chocolate ice cream, keep me. But if I can't eat chocolate ice cream, let me go. He said two things: as long as I could eat chocolate ice cream and watch football on TV. And she said she was a doctor too, and she said I had no idea he loved football that much. But as long as he could eat chocolate, and when he became unable to swallow, they said, well, you want to put in a feeding tube? And she said, no. If he can't eat chocolate ice cream, it's time to let him go. And then I've got an optional. We can talk about the actual nuts and bolts of how we die. It's optional at the end if anybody wants to hear that. So decision making, the transactional analysis. And then there's a magic word that you say in the hospital. There's some magic words that you can say in the hospital. If you say comfort care, everybody knows what that means. But the people taking care of you, the doctors taking care of you, are going to assume that disease is the enemy and they intend to fight as hard as possible against that enemy unless you tell them differently. So you kind of have to tell them differently. In secret anonymous interviews, oncologists have testified, yes, that they have given chemotherapy when they one third of oncologists said that they had given chemotherapy when they knew it was not going to do any good at all, because the patient wanted it. And then when you interview patients, they ask for things that they really don't want because they think their family wants them to. So you got a lot of dynamics there. So you got, oncologists make a ton of money on chemotherapy. It's just one of those things. They like to do chemotherapy in their office because they capture it all, the infusions. But we're an odd profession. We're an interesting profession. We have a lot placed in our hands, a lot of decision making placed in our hands, and we're expected to think of the other person. And that's Max and I talk about things like, with a stroke of a pen, I can cost Medicare thousands of dollars, just by ordering and signing something. So we're expected to be good stewards of that, and to keep your interest and to treat you like we. But there's some human nature stuff that, for one thing, I'm not telling you the hospice that I'm medical director of because I'm not here to advertise them. And it's not the one you're having come talk, but I've been board certified in hospice and palliative care for 20 years, and I'm a hospice medical director for one of the hospices in North Georgia for 20 years. Somebody comes on my hospice, they pay me. The hospice pays me to be the medical director, so that's a conflict of interest. That we take that pretty seriously, conflicts of interest. So let's say that you've made your decision. I have something called a goals of care. There's a goals of care discussion and end of life discussion that we kind of have a set way that we talk about. I ask people questions about their problems, their medical problems, to assess where they are in the knowledge of their own medical problems, and then people pretty much know what's coming, and I'll ask them, what do you think? How do you think you're doing? How do you think you're going to be in 6 months? How do you think you're going to be in 12 months? And then they'll answer, and I'll say, well, you're right. Yeah, you're probably right. Time's getting short. Or I'll say, no, you're wrong. I'm afraid time's getting short. You need to think about that. And I just, matter of fact, I try not to sugarcoat things. Time's getting short. I don't make the kind of predictions that you see on TV. So I had this guy that I gave him 3 months to live, right? I gave him three. At the end of 3 months, he had not paid his bill. So I gave him another 3 months to live. No, I tell families, I'm not going to, even in hospice, even a few days before the end of life, I just tell them, look, time is short. You need to spend the time to be together as a family and to be with your loved one. I can't tell you. I have several other stock phrases. We know where this bus is going. We're not trying to make it faster or slower. We're just trying to make the road smooth. But I can't tell you when the destination's going to arrive. So when you've made this decision, what do you want to do? You want to communicate the decision. So that's number 3, communicating your decision. Many times we'll have families gather and the patient is unable to make a decision, and they kind of look at each other and say, well, I don't know what he would want. I don't know what he would want. And in that situation, you're more likely to get somebody who gets too much procedures and too much care, because they're going to say, well, just do everything. Do everything for daddy. I don't know. Or then you get, and doctors will tell you, it's always the one from California that flies in. And everybody else is pretty much on the same page, let's keep daddy comfortable. And then the one from California flies in who hasn't seen him in 20 years and was was very anxious to get away, and that's oh, what are you doing? No, you can't do this. You got to do everything. You got to do more. And that's you want to communicate these decisions before you get to the point where you can't communicate them. So as I said there, you want to communicate with your family and your doctor, and you want to talk with them about, you've already talked with them hopefully about making that decision. I give you a couple of other guideposts that we have. So I was talking to a lady earlier this week. So the American Cancer Society used to say women should stop getting mammograms at age 70. And then they changed it and they said women should stop getting mammograms at age 75. What's the life expectancy in the United States today? Average life expectancy for everybody, just taken all together. 79. It is now 78. We lost a year on the average during COVID. We lost 1.5 million people in COVID, which skewed the average. So the average life expectancy in the United States is 78. Another statistic, if you reach the age of 70, you have a 50% chance of reaching the age of 90. When Social Security was instituted, average life expectancy in America was 75, 80 years ago, right? Average life expectancy was 69. So they set retirement age at 65. Well, we've added 10 years of life expectancy in that 75 years. And that's one reason Social Security's, that's one reason, plus inflation and a lot of stuff. So people are living longer on Social Security. Why are they living longer? Well, why are they living longer? Clean air and water, less pollution is a big, big deal. We don't have those unmuffled engines like we had when our parents grew up. Unmuffled engines and pollution and things. So we've done a lot with that. School shots, immunizations. My grandfather died with a heart attack. And he had been taking sodium bicarbonate for heartburn. It wasn't heartburn, it was angina. So, and that was in 1963. So we've had a lot of advances in heart. We're actually doing fewer heart bypasses now than we did 15 years ago because we're doing more stents, more selective stents. We're saving people from heart attack so well that we now have an epidemic of congestive heart failure, right? So, and I mean, I remember being an orderly in high school, and we rarely saw congestive heart failure, but heart attacks just like this, every day. We had no medicine for heart attack. When I was an orderly, I would watch them, and all they could put oxygen on somebody and give IV morphine, and that was the treatment for a heart attack in 1969, 70. So we've come a long way, and we've extended life expectancy to age 79. So now the American Cancer Society, in talking about mammograms, say a woman should get mammograms as long as she feels healthy. And then family doctors talk about life expectancy. If you've got 10 years of life expectancy, go ahead and get your cancer screening. Get your colon cancer screening, prostate cancer screening. If you've got less than 10 years of life expectancy, maybe think about not doing those things. All right? So if you've got, and the way you kind of determine that is you look at what your health has looked like and what your arc of, your life is right at this point. If it looks like, that arc is going to be, kind of on a downhill slide. If you're over 80 and you're taking a handful of medicines, and you're losing weight every 6 months, and you're getting a little more feeble, you probably do not have a 10-year life expectancy. So if you're in that situation and they say, well, get the colonoscopy, you just say, probably not. So, you can be practical, and you can use guidelines for things like this. So you communicate the decision with your family, your doctor, your pastor, and then you can document the decision. So there's a couple of ways of documenting the decision. And if you if you Google Advanced Directive or Georgia Advanced Directive, you'll get that website that I put down, aging.georgia.gov. And on that page, if you just type that in, on that page there'll be a link, a hyperlink down about halfway down, where you click it and it'll give you the PDF it'll take you to the PDF of the Advanced Directive. It's 29 pages. Okay, 29 pages. I printed it out. I'll leave one with Max. Most of it is instructions on how to do it, instructions, and it's in big print. That's why it's 29 pages. But it tells the duties of the healthcare advocate and different things like that. So then finally you get to the nitty gritty. I select the following person as my healthcare agent. So you can choose somebody to make decisions if you are unable to make decisions. And then you start writing down what your preferences are. And a backup healthcare agent, a second backup agent, and then you authorize them to make your admission or discharge decisions and decisions to provide care or withhold care. And then organ donation and donation of your body. My cadaver in medical school she had been through a lot. There were some organs missing, that we had to go to other people's. You remember that, man? Yeah, you had to go to somebody else's place and study the gallbladder because your cadaver had a missing gallbladder or something like that. Treatment preferences, and you can write these things down. So it doesn't have to be notarized, it doesn't have to be signed by an attorney or anything like that. The main purpose of this is to inform the person who's going to make the decisions what it is that you want. Because too many times you see people sit there and say, I don't know what you would want in this situation. So you tell them. You tell them and you write it down. And that way the same way that you can make same way you can make funeral arrangements, and same way you do trust and a will and things like that. And this is just belt and suspenders for healthcare decisions. And then there's now. I don't know if you're going to have EMS in here or 911 or whatever. If you dial 911, what are they going to do? They're going to do CPR on you. So why call them? So there was a conundrum in Georgia and in other states too about, well, goodness, you call 911. If the ambulance comes to your house, they're going to do CPR. What can you do not to? Maybe you just want to transport to the emergency room and treatment for pneumonia, but you don't want CPR. How are you going to tell them that if you're not able to tell them that? Well, there's another concept. So there's a second thing called POLST, P-O-L-S-T. So that's the physician's order for life-sustaining treatment, the POLST. This actually does have to be signed by the doctor. And down here, it lists, do you want resuscitation and medical interventions, comfort measures, full treatment, antibiotics, no antibiotics, or determine if infection occurs, and different things like that. And then it's signed by two doctors, and by you or your authorized representative. This is an enduring. This is something that's transferable. You keep this at your house, and if it says no CPR, then the 911 is not supposed to start CPR. This is an order. This is a doctor's order. So some people put a little tag on the door that says, I have a POLST. And the EMS know what that means. I have a POLST. It's in the freezer. It's in a plastic bag in the freezer, or wherever it is, somewhere permanent. And when you go in a nursing home, you do a POLST, so that if you go to the hospital, the POLST goes with you to the hospital to tell them. Because if you go to the hospital without anything and nobody's making a decision, well, you're gonna wake up with tubes in every orifice, and that in the absence of directions not to, they're going to do everything they can think of to do. One of the things about the hospital is it's hard for these guys who are working hard trying to save people's lives to walk into a room and pull back and say, no, we're just going to keep you comfortable, because it's sort of, when you're working, you kind of get a working attitude. So it does take some effort to go against to row against the tide for some of this stuff. And then, so those are the documents. And I recommend that you have those and discuss it with your family, and then they've got it in front of them. They know what to do. And when the guy in the ICU comes and says, if we don't put him on the ventilator now, we're probably closing the door. We'll probably need to be telling him goodbye if we're not going to put him on a ventilator tonight. Then your relative or friend or spouse or healthcare agent has that in front of them, and they say, he said he didn't really want that. He said he really didn't want that because it's not going to change his disease. It's only going to prolong some misery, and he didn't want that. So I'm confident that he didn't want it, and the doctor says, I'm glad you're confident. We'll keep him comfortable. And so, I like the title that you guys had, Getting Your Ducks in a Row. So that's the way it plays out if you have your ducks in a row. Then there's, now I'm going to get into opinion. So, we're old enough to remember things like this. My opinion is we would not have Medicare if John Kennedy had not been assassinated. Think about that. He had two bills. He was terrible with Congress. He was terrible. He was as bad as Jimmy Carter with Congress. He had two bills bottled up in November when he was killed, a voting rights bill and a jobs bill. And they were hung up by Senator Byrd from West Virginia and by Richard Russell from Georgia. They were hung up. They weren't going anywhere. And his team of Harvard boys, were not getting anywhere with Congress. And he died, and basically Johnson came in. And of course, he had been a master arm twister in the Senate before he was vice president. And Johnson came in, and in his first speech to Congress after the assassination said, if you want to honor this man's death, pass these blankety-blank bills. And he had them passed by Christmas. And then in January, in the State of the Union, he outlined the Great Society, his vision of a great society. And then that summer, they passed, and the AMA had a publicity campaign against Medicare. I remember that. I remember as a child seeing those TV commercials. He passed Medicare, Medicaid, Head Start, Job Corps, Youth Corps, Title I reading. That's Johnson, the first year after Kennedy was assassinated, with the help of liberal Midwestern senators and Northeastern senators. This kind of stuff would not be passed today. So we got Medicare. How many of you on Medicare? How many of you like Medicare? I mean, people on Medicare like Medicare. And you think about so the approval rating for Medicare was 50-50 the first year, and by the end of the second year it was 90-10, because you had all these farmers and all these old workers who never had insurance before. I can get my hernia fixed. The old farmer, throw away that truss, get your hernia fixed, and then Medicaid for poor people, and then in 1980s we got again a Democratic majority Congress. We got home health. How many of you have had a home health? That passed a Democrat majority Congress in the 1980s under Jimmy Carter. He knew the kind of things that we needed. We also got hospice agencies passed in the 1980s. So these are things that you think that would pass today? Home health would not pass today. It wouldn't be passed. You had all those liberal Midwesterners, and then Teddy Kennedy. So those, and then just interesting I like history. I like to look at history and talk about and debate, things like that. What ifs. But those things were done in a different time and a different attitude. So the term hospice comes from the same root word of hospitality, hospital, hospitality, hospice, and it means to take care of somebody. To take care of somebody, and that concept started in Europe, and the idea is that when you make a decision, the cost outweighs the benefits. What I want a good day, as good a day as possible every day, and I'm not trying to prolong my days. I'm just trying to have good days. That's hospice. So the hospice concept is, you forego curative treatment. You don't do any more treatment that tries to cure the disease. you do is you take anything you can for comfort and to have a good day today. And if it's pain medicine, if it's anxiety medicine, if it's medicine for depression, for agitation, you use those medicines and you treat the symptoms and you try to prolong somebody's comfort as long as you can rather than prolonging their life. So that had been developed in the 60s and the 70s in Europe, and then it was kind of transferred. Once home health was in place, then that gave a template for making hospice agencies. And hospice is a Medicare benefit. So I use that phrase with families so that they'll understand. You're going to access your Medicare hospice benefit. We're going to access your Medicare hospice benefit. Everybody has a Medicare hospice benefit. And these agencies provide that care. 95% of all hospice is done at home, where the care is done by family members or hired caregivers. The hospice, so the law sets down how a hospice agency has to be incorporated. You got to have a medical director, you got to have nurses, you got to have a social worker, you got to have a pastoral counselor, you got to have a volunteer coordinator. And then it sets down, you meet as a group to determine the care of the patient. And that's called the IDT, it's called several different, IDG, interdisciplinary team or interdisciplinary group. And the way it's supposed to work is that the medical director doesn't have any more control than the nurse's aide. The nurse's aide can say, look, I've been out there every day and she's having trouble getting out of bed. We need to get her more pain medicine. And the medical director is supposed to say, you're right. You're the one on the ground. And the team determines the direction of care. And that's the way the law has set up hospice agencies. You will occasionally hear a nonprofit hospice agency tout the fact that they're nonprofit. It doesn't matter. The rules are the same. The Medicare rules are the same. So that's kind of, they use it as a marketing ploy. How would you choose a hospice? Well, how do you choose a bank? The rules are all the same with all the banks, right? You can't go to one bank and get a 5% interest rate and go to another bank and get a 2%. You can't tell one bank, the one bank tells you got to have 10% down. And I don't want to do that. I want to do 5% down over at this other bank. The rules are the same for the banks, right? So you choose a bank based on personal relationships or recommendations or something like that. So you choose a hospice the same way. Tip O'Neill said, all politics is local. And I like that phrase. All hospice is local. It's that nurse's aide who's coming to help somebody take a bath. It's that nurse that comes and assesses and helps order medicines. So your hospice work is done right in the bedroom, with the people who are coming out. So if you have somebody who's had a good experience with a hospice, the way they took care of their mother, that could be a hospice you would want to choose. So watch out for marketing. Be careful with marketing. Sometimes they'll try to sell the sizzle when they don't have the steak. And that's what I always tell our team. Don't sell the sizzle. Don't sell me the sizzle unless you got the steak. So the case managers at a hospital, they come in and they give you a list and they make you choose one from the list. So do your homework beforehand. What your friends and family have known about different hospices, or go to some presentations. The presentations are usually given by the marketing person from the hospice. So it's good to meet the nurses, and good to meet the ones who will be coming to your house or to your loved one's house. So you got different agencies that can help you. The home health is set up so that you have to have a skilled nursing requirement. So home health can't come see you unless you have a skilled nursing need. So it might be wound care if you've got, a heel wound, or it might be post-op care if you've had a hip surgery. And once they find the skilled nursing need, that opens up a lot of other stuff from home health, social worker, PT, nurse's aide, things like that. But the requirement is you have to have a skilled nursing requirement, first of all. And there's a list. They have a book from Medicare. They have a book, and they'll sit with you and they'll evaluate. Sometimes I don't know. I'm not sure. A family will call me. We want home health to come see Daddy. What does he need? Well, he just needs somebody to come see him. He needs somebody to help him get a bath. Well, that's not a skilled nursing requirement. So we got to find a skilled nursing service requirement in order to open up the door to home health for the bath aid and things like that. So see, you may not have known that before, but that's, and I'll tell you something else about PT. I'll have people say, well, my PT's up. I've had 3 months of PT. I want to keep going. Well, PT is under Medicare. If Medicare is going to pay for it, obviously Medicare's got PT rules, right? So first of all, in order to qualify for Medicare to pay for PT, you have to have rehabilitation potential. You have to show that you're a candidate, that you have rehabilitation potential. And then the PT sets a goal. So you're here physically, and the PT sets a goal for you to be here physically in 6 weeks. Well, if you don't meet the goal, Medicare might give you one more try at it. But ultimately, if you don't meet the goal, Medicare quits paying because you didn't meet the goal. And if you meet the goal, Medicare quits paying because you met the goal. It's not, so PT in home health is not something you could continue indefinitely. And people think that it is, but it's not. It's under Medicare rules. Home health care is great, and you kind of see that as a kind of a hierarchy: home health care, and then palliative and hospice. We'll get referrals from home health care agency. This patient needs hospice. We're doing all we can, but the patient needs hospice. And then the most confusing term we've had in this area in the last 20 years is palliative care. So technically, palliative simply means symptom relief. And in the big hospitals, where there's a team for everything, there's a palliative care team. And what they like to do, what the oncologists like to do is, I'm giving the chemotherapy, consult the palliative team to handle the pain medicine. So the palliative doctor then comes in at a big hospital, does a consult, and orders the pain medicine and adjusts the pain medicine. That's at small hospitals. It's kind of like it's a little bit. It can be redundant, and you can be confused, and even a palliative person might not know what they're supposed to be doing, because really we would have called it good medicine back in the old days. but palliative is symptom relief. So you can have palliative care without stopping curative attempts. So you can have a cancer, continue chemotherapy, and have palliative care come to your home for nursing assessment. That would be kind of a step above home health. You would have to have a need for the palliative care, and usually that would be ordered or documented by the oncologist. And you would get nurses aid, you would get other services from the palliative care, but then specifically they would be looking at the symptoms that you're having and providing pain relief. And it might be that it's a level of, say, narcotic prescriptions that home health is not comfortable with, because they don't do a ton of that. And maybe the oncologist is in Atlanta, and a palliative care agency would come to see you and would handle the pain medicines, the anxiety medicines and stuff like that. So that's where palliative fits in as an outpatient in the home. And it is confusing, because once you then once you make a decision not to pursue curative measures, then you can do a hospice agency. But for example, I had a guy with aplastic anemia, and basically he was getting transfusion every 2 weeks, and that was what was keeping him alive. So he would not qualify for hospice because he was doing a transfusion every 2 weeks. Somebody on dialysis would not qualify for hospice because of doing dialysis. So they might qualify for the same type of services from a palliative care agency. Usually, though, I tell patients, if you've done your homework up at number 2, and you know what your goals are. So what's your goal? To get well and throw away your crutches and run down the sidewalk. Well, okay, what's your second goal? If you can't do that, once you decide what your goals are, you tell us what your goals are, and we'll pick the agency and the situation that best meets that and can help you meet those goals. So that's kind of what I, when I have a session with a family or with a patient, that's kind of what, don't tell me the diagnosis, tell me the symptoms. Don't tell me what agency you want, tell me what kind of care you want, how you want to be taken care of. How do you want to be taken care of? And then let me see what fits that. If it's going to be home health or a palliative agency or a hospice. Most palliative care then is also done by hospice agencies, and there's a marketing ploy to that. They want to get you in palliative so that when you transition to hospice, they're there and you'll be there. You'll be their hospice patient. So there is some marketing to marketing palliative care, telling people, oh no, you don't have to. You don't have to die in 6 months. You can you can keep doing the chemotherapy. But we can have palliative come in but then they kind of got their foot in the door for you. And then you got long-term. All right, I'm going to go back to opinion now. Assisted living is great if you only need a little assistance. If you need a lot of assistance, it's rough. I had a lot of falls. A lot of people fall in assisted living. We had one assisted living down closer to Jasper that was sending half their patients to one hospital and half to another so that no one emergency room would see all the falls. That's what I accused them of. But assisted living, my opinion now, you may remember and you may have defined benefit pensions from some companies, had defined benefit retirement plans. And in the 80s and 90s, that changed. Most of them tried to change to defined contribution. So, which is like a 401k. So defined benefit were kind of like the teachers' entitlements, and the Lockheed Union and the GM and Ford and AT&T Bell unions. You had a defined benefit that you were going to get, and it was scaled to inflation, and you were going to get that no matter what you put in. The company was going to ensure that. Well, in the 90s, they realized that was not sustainable, so they changed to defined contribution. Basically, you put in a defined contribution and it gathers interest and you're going to get it back like a 401k. But if you're not going to get back more than you put in, defined contribution. So right now, these assisted livings, they're tagged right about $5,000 a month, which is very close to a defined benefit pension from Lockheed and Ford and GM. And so you got these widows, and I say widows because the women live longer. So you've got these widows who are in assisted living at $5,000 a month. Defined contribution plans, when all these defined benefit plan patients kind of fall out of the picture, defined contribution plans may not sustain. I would not invest in assisted living right now, because in another 10 years, that model may not be sustainable, because pensions may not contribute enough to keep those things going. It's just, I like what? Oh, I'm blanking on now. My memory's kicking in. That guy that always takes a cockeyed look at finance. He's on the radio. Yeah, one of those guys. But I like taking a cockeyed look at this, and I'm thinking 20 years from now, these assisted livings may be malls. They may be like malls and have gone to something else. Anyway, and then long-term care. So skilled nursing homes. So you do know Medicare does not pay anything at all for skilled nursing homes. Skilled nursing homes are paid by Medicaid. So in order to be in a skilled nursing home, you have to qualify for Medicaid. And there's a 5-year look back on any financial transactions to try to qualify you for Medicaid. So my mother is 90, lives in a condo in Jasper that I own, or I'm paying for. It's in my name. She has divested herself of her assets. So if she has to go into a nursing home, she will immediately be eligible for Medicaid. So there's some different strategies that attorneys who specialize in elder law can advise you on. And one of those is that if you, let's say you have a patient with Alzheimer's and they break a hip and they come in and they've got to go to rehab. You get the rehab, Medicare gives so many rehab days, right? So you can go, and the rehab is in the nursing homes. So they'll take you as a rehab, but when your Medicare days are up, they have to discharge you. If you want to stay there as a skilled nursing patient, you have to qualify for Medicaid or pay cash or qualify for Medicaid. And I've had patients that paid cash until they spent all their cash and then qualified for Medicaid. But you might want to explore getting that done, getting stuff like that done first. So that's kind of, that kind of hits the, assisted living. There's another thing besides assisted living called a personal care home. The assisted living and personal care homes are not paid by anybody unless you have some long-term care insurance and it fits under your long-term care insurance. Personal care homes and are not licensed, I don't think, by the state. So there's a personal care home is like a boarding house, and those costs can be really lower but the level of care is also a lot lower. You know, those homes would not take somebody. They might not take somebody with twice a day insulin, where you had to measure blood sugar and then do twice a day insulin. The assisted livings will check your blood sugar and they'll measure it and they'll give you they usually add on a $400 a month surcharge and different things like that. So, so personal care homes are an option for patients who can't afford ALF, assisted living facility, PCH, personal care home, SNH, skilled nursing facility, SNF, they call them. All right, so that's the, I wanted to open it for questions. That's kind of the end of my talk, and I figured you probably had questions, and then we had, yes, sir. Well, good. I'm glad. Yeah. Yeah. My kids probably don't know any of the medicines that I take. I'm a real private person. My wife probably doesn't know the names of all the medicines I take. We kind of got to get out of that. We got to get out of that mold and do a little more talking, a little more communicating. Well, this is the official Georgia, that was legislated. As you can see, a camel made by a committee. It used to be just very simple, a one page, very simple. And in Georgia, there's a clause in here that says that this legislation doesn't negate any other type of advance directive. So any advance directive is effective in Georgia. And I'll tell you a secret. It carries no force of law or contract at all. Your healthcare agent can decide something different from what's in here. And there is no, I probably shouldn't have brought that up, but it doesn't carry any force at all. I mean, if let's say your healthcare agent decides they want you to get CPR, who's going to sue your healthcare agent for having you get CPR against your wishes? Bzz. Nobody. Well, again, those are instructions, and there's no heart in the legislation to punish somebody for breaking that rule. Nobody's going to get punished for breaking the rule. I'm telling too many stories. I get into a personal, not a vendetta, but I got into something real personal about 20 years ago. There's a computer source in Georgia called GRITS. And when you give an immunization, you're supposed to list it in GRITS. So that in my office, I can pull up your GRITS account and I can see every immunization you've ever had. So that's very useful to know. So I won't give you another pneumonia shot because you had one last year at somebody else's office. So we had drugstores that were given pneumonia shots, specifically pneumonia shots, and not putting them in GRITS. So I was at the Georgia Academy Family Physician. Jack Roof was there, and I made a resolution. We passed a resolution. We resolved that every person every agency that gives an immunization should be required to put it in GRITS. And there was a guy who wasn't there that day that was from Gainesville, David, the public health director in Gainesville. And the next day he was there, and we had passed this resolution, and I was feeling pretty big britches. And he said he had been on the committee at the legislature, and he said, it's already a requirement. It's in the law that if you give an immunization, you're required to put it in GRITS. And I said, well, what's the penalty? And he said, there's no penalty. And I said, we need to go back to the legislature and make a penalty if you don't put it. He said, legislature's not going to do that. They're not going to make a penalty. So basically, the essence is communication to your family decision makers, and that communication to the people who are taking care of you. And that is, we do it informally all the time. We do it informally every day. This is an added level of assurance for your family. But, which brings up another point. Why should you do hospice rather than just go into the bitter end in the ICU? Well, surveys done for your family, your family members who are left behind, show that if you have a, quote, good death, their levels of stress, depression, and anxiety are lower 6 months later than if you have an anxiety-ridden death. So you're doing it for them too, for the ones you leave behind. Yes, ma'am.
For rheumatoid lungs, and she filled this out, and has it on the coffee table. And I was told by the palliative care people that if I come in and something's happened, to call them first as opposed to 911.
That's a good thing to do, because that kind of breaks that chain that might get you going down a road you wouldn't want to go to. Because she's already said she doesn't want some things. Then yeah, why call them if you know? Yeah, no, that's exactly right. And our hospice nurses tell the patients, don't call 911, call us. And we'll tell you what to do, and we'll come out, because they got somebody on call. We'll come out to your house. Yep. If you go to the ER, so it's a Medicare benefit, right? So if you go to the ER and you get ER treatment for the same condition that Medicare is paying the hospice, it breaks that contract. It's called revocation, and it breaks that hospice contract. And some hospices will try to take you back afterward, but like we've got one patient right now who's done it a couple of times, and if they do it again, we're not going to take them back into hospice. And what are you talking about? Giving enough medication that somebody would die? No, we don't do that. No, not in Georgia. That's not allowed in Georgia. So it's interesting. There's a lot of interesting things. That's allowed in Oregon, and it's only about two or three states that it's allowed in. So people will have sometimes that misapprehension. So I will tell you that if I were stuck on a desert island and could only have one medicine, I would want it to be morphine. Morphine is God's gift to humankind in the opium poppy. Yeah. We know it relieves pain, but it also relieves anxiety. You may not have known that, and it also relieves shortness of breath, the feeling of shortness of breath. So it's a very versatile medication, and we use it liberally for pain, anxiety, shortness of breath. We give Valium for shortness of breath, Ativan, the benzodiazepines for anxiety. But the dividing line is our intent, and that's how we're taught. We'll give as much pain medicine as we need to for pain, and if inadvertently the patient passes away while we're doing that, that's not our intent. So our hearts are pure, and our hands are legally clean. Our intent is to relieve pain. In those states where physician-assisted suicide is legal, the intent is to end life. So we can't do that in Georgia. That's not our intent. And if you're talking about a situation where somebody's in their last 2-3 days of life, that hospice nurse is going to be there every day administering. She's going to educate the family on how to administer pain-relieving medications. The surveys of and the reports from states who have assisted suicide show that first of all, you have to be in your right mind. You can't be Alzheimer's and cognitively impaired to request it or to give it. You have to take it yourself. Nobody else can give it to you. That's part of the legislation in those states. So over half of the life-ending prescriptions that have been prescribed in those states go unused. The patient changed their mind or just wanted to have it just in case. But over half of those medication prescriptions are unused. And it's a really interesting thing. It's kind of like suicide hotlines. Suicide is a perfect storm of circumstance and thought and the things that come together, and finally someone decides that life is so painful that death would be less painful, and they attempt or commit suicide. If we can break that chain with a suicide hotline, 90% of the time, they don't get to that same spot again. So that's the usefulness of suicide counseling and suicide hotlines. So I didn't mean to have such a long answer to the question, but one of the nurses was listening to, we had a patient who died, and a family member called another family member to tell them that they died, and she overheard this family member say, yeah, the hospice nurse came in and put Mama down, and no, we don't put Mama down. Well, but I know you've got something you got to wrap up here. You are welcome. Thank you for asking me. I'm going to leave Max these copies of the Advanced Directive in the Pulse. The article titled "Why Should Doctors Die Differently?" and I'm just going to leave How Doctors Die. I'm going to leave it with him in case anybody wants to.